Um,
Hi, hello,
Hello, good afternoon. I'm
Hello.
just waiting to hear
good afternoon.
from the organizers if I should keep my camera on, or let me know when you are happy for me to start also.
Hello, Carol. Hello, Caroline. How are you?
Hello, Emmanuel. Nice to hear you.
Yeah, it's been a while.
Um, so you can hear me and see me okay? Should I turn off my camera? Is that
No, no,
better?
no. It's fine. It's fine.
Yeah? Okay.
Yeah, it's okay. Yeah, so we'll start very soon.
Okay.
You can on your camera. We want to see your face first before you start.
Okay. Okay, good.
Okay, so good day, everyone.
Good day, sir.
Good day, sir. Yeah. So when are we starting over there? Can we come up from there? People
Just,
have already,
ju-
people have
just give
already
us,
joined.
just give us
Eh?
about, just give us about 1 or 2 minutes. We are trying to
Okay,
connect the camera. Yeah, connect the camera here.
okay.
Yeah.
Meanwhile, I'll just try to share my screen to see if everything is working. If that's okay.
Okay.
Can you see slides?
Yeah, it's fine. Very
Perfect.
good.
Thank you.
Set it to let me open the. I've opened it. Seriously. Okay, can you see it? Yes. Can you see us here? You can see it. Change this to landscape.
Yeah, okay. Have you seen she has already projected a slide. Can you see the slide?
Yes, you can see the slide.
Okay.
Yes.
Read the training. That was all to try.
So when you are ready, just let me know because I will need to introduce her.
Yeah, I'll be back. So I ready now.
Are you ready?
He's telling me you can't start. They should start. Take it. Go back. Please select settings. Let's just continue. Yeah, you can start, sir.
Okay. Okay, so good afternoon, everyone. I want to welcome every one of us to this the May edition of our online mathematical modeling presentation. So this month we'll be having Dr. Caroline Franco from the Department of Biostatistics and Health Data Science, School of Medicine, Medical Sciences and Nutrition, University of Aberdeen, United Kingdom. I've known Caroline for roughly close to 7 or 8 years now. So at least when she was doing her PhD. So she's been a friend and also a collaborator. So she'll be talking on mathematical modeling in context as it relates to COVID-19. So you are welcome, Caroline Franco. Thank you.
Thank you so much, Emmanuel. Thank you so much for the introduction and for the invitation. I'm very happy to be able to share a little bit of my side of experience. And you're definitely going to recognize lots of the stuff that are in my presentation because it comes through some of our collaborations. So as Dr. Emmanuel Bakari mentioned, we first met, I think it's almost 8 years ago when we were both
in Bangkok.
The Oxford, the Mahidol Oxford Research Unit in Bangkok, and we continue to be involved in similar projects throughout the COVID pandemic. And part of my presentation, or most of my presentation today, is going to be a little bit of the experience that I had during that period. So thank you so much.
Great. Thank you. You're welcome.
Well, as you already have been introduced, my name is Caroline Franco. I am originally Brazilian, but I'm now based in the United Kingdom in the University of Aberdeen. I'm actually trained as a physicist for my master's and PhD degrees in the University of São Paulo and São Paulo State Universities. I also spent part of my PhD and some postdoc period in Oxford before coming to Aberdeen, where I am a lecturer now. I also lead a master's program in health data science. And as Emmanuel said, this is all part of the School of Medicine, Medical Science and Nutrition that we have in Aberdeen. Aberdeen has a very strong research, let's say, a very strong focus in health and care research. We have a very big campus only focus on medicine and health research, in collaboration with the National Health System. So the NHS is the public health system that we have in the United Kingdom, and Scotland, as part of the United Kingdom, has sort of a slightly different system, but is still part of the NHS. So there are lots of collaborations happening here in terms of research in health and care at local or regional or national level in that sense. A little bit more in terms of exactly where I'm coming from and my groups. I'm part of the Biostatistics and Health Data Science group, which is a very interdisciplinary group within the School of Medicine. Even though we are within the School of Medicine, we have very varied backgrounds. I have my physics background. I have colleagues with mathematics, statistics, engineering, as well as clinical, medical, biology, or even social sciences background, and all of it to produce this sort of multi-dimensional approach to health and care research. And part of it is also our training programs, so the masters and online courses that we have, as well as the research. So there's a lot of research going on in terms of health and care in the University of Aberdeen. Sorry, I just wanted to check if the mics are on, because I feel like I'm hearing my voice. Yeah, I think if we can make sure that the mics are off. So yeah. Yeah, I think it's better now. Thank you. Thank you. It's just that because I kept hearing my voice, so I couldn't think through it. I'll just keep going. Let me know if for any reason you cannot hear me well.
Thank you. We are hearing you. Go ahead.
Okay, good. So yeah, in terms of research, there is a lot of research going on in terms of health and care, including use of data-driven machine learning models. But my particular area is the use of dynamic models, mathematical models in global health research, public health research. So looking at these types of questions where we use the models more than to publish papers, but to try to produce something useful to inform health decision making and at a public health level. So that's where my little experience, or my story about my experience during the COVID pandemic enters. So around the time that COVID emerged in Brazil, I was still doing my PhD, and as many of us working in mathematical modeling or public health, we had to swiftly change our focus into this new health emergency. And we saw lots of data-driven models popping up. We ourselves worked a lot on basically just visualizing the data, processing the data, trying to find data. Sometimes there was a big struggle to find accurate data to try to track the state of the pandemic, and that was already a huge challenge. But what I wanted to mention is that we also saw lots of things like people using statistical or machine learning models to make predictions, to try to find peaks or new cases for next week, and so on. Or using exponential models to try to predict these things. And this sort of data-driven models can work in some contexts, or up to a point, but they cannot explain all the nonlinear phenomena happening in the underlying dynamics. They cannot explain what happens when the pool of susceptibles in your population starts declining, because more and more people are getting infected, and that at that point a simple exponential growth model doesn't work anymore, or a statistical machine learning model might not have enough in the data to be able to predict what is happening in the foreseeable future. So that's where our mathematical models come in, because we take into account this nonlinear dynamic relationships happening between these different subpopulations of susceptible, infected, recovered people explicitly. And we can also explicitly explore the impact of interventions in the disease dynamic as it unfolds. So this collaboration, like I mentioned, is started within our group in Brazil. Professor Roberto was my supervisor at the time, and we had a couple of other colleagues. So we started talking about what can we do with the data? How can we actually use that in produce models or analysis that can be useful in the public health context, and not just be someone else producing plots that are not that useful. And at the time, we started producing our data analysis and visualizations, but also started developing our own mathematical models. And around the same time, we started collaborating with the International Modeling Consortium, which Dr. Emmanuel Bakari was also a part of, where we developed different types of mathematical models to respond to different needs, to different questions from policymakers and from and even within academia in research. So we had our Professor Elisa White and Rima Shweta were sort of the founding members of this modeling consortium from Oxford, but that quickly expanded. I've added here a few of the institutions involved across the globe, but in each of these countries, it could be several institutions, and sometimes not even academic institutions, also just stakeholders, policymakers that decided to collaborate with us to use this model to inform public health decisions. In Brazil, particularly, we had a modeling team that started with our mathematical modeling team in the Institute of Physics, Theoretical Physics in the São Paulo State University, but branched out to close collaborators, and later on became even bigger with new collaborators across the nation. For our international modeling consortium, you probably heard a little bit about it already. We had an interactive interface. You were able to access the model and input data from your country, not only cases and so on, but also demographic data, contact rate data to parameterize the model to your specific situation, and then that would give you model results. And more than just using that, like someone just inputting data and that giving you back results, but we would work collaboratively with any policymaker that wanted to use this modeling input. So the sort of partnership that we have is that we will have meetings from the start to parameterize the model together, to understand the questions being asked together. So if you are trying to explore a new set of interventions or a new set of strategies, for example, to reopen schools or to deliver vaccination, we would work together to parameterize the model in a way that made sense in reality. All of that had this underlying mathematical model that, again, is incorporating these nonlinear relationships between the different subpopulations, susceptible, infected, recover, and the disease biology, but more than that, the health system and how we responded to different symptomatic presentations, or how we classified hospital admissions and so on. And all of this, I don't know if, how many of you are already working with this kind of modeling framework, but you might recognize it as a model diagram here. So each of these little boxes represents a compartment and later on an equation, and all of it is informed not only by the biology, like I said, but also health systems and policies, and even the way our databases were represented and would classify these things. So the models that we did, particularly in the context of Brazil, produced a bunch of results, some of it published in scientific journals. But more than that, we also had this online platform. This is only for the Brazilian consortium. This online platform was a result of a collaboration between researchers, reporters, clinicians, policymakers, everyone working
talking to you.
for free, basically, to produce results analysis and some blog posts and so on, to inform the public, media, and sort of in a more approachable way for the public. So this is what it looked like from the outside, but I want to talk a little bit about the what is on the back end, the models that we developed. So our baseline model, based on this diagram that I presented to you before, was informed by not only the biology, but also how symptoms were described. Usually in the healthcare system databases, you would have a way to track if the symptoms were mild or severe, if there was hospitalization or not, the kind of hospitalization, if it was a normal hospital bed or if it required intensive care or ventilators and so on. So different health systems might work differently. We actually adapted this model a little bit only for the Brazilian context because we didn't have a differentiation between ventilators and non-ventilators. Everything is called ICU in our kind of reporting system. So we adapted it in a way that made sense with our health systems, made sense with our classification protocols, and but basically, this is the baseline. This is how we understood the system worked like, and the disease worked like. And this was all parameterized for demographics for the country. So not only population numbers, but age distribution in the country. We used this contact rate matrices. So it's basically data on how many contacts a day people from different age groups are having throughout the day. So it's an average. So that would sort of give us a picture on of how frequently certain interactions occurred and that would inform our transmission rate, right? And all of that was incorporated as like a calculation of the overall contact rate that is part of the force of infection of the disease. And as I mentioned, like just for those of you that might not be very comfortable or not used to this with this representation, when this diagrams represents each little box represents a subpopulation, either individuals that are susceptible or pre-symptomatic, which here we call exposed, or infected, but there are different types of infected people, right? People with or without symptoms, hospitalized or not, the ones that need treatment or not, and so on. So each of these boxes will represent an equation in our system of differential equations. And more than that, actually, as we decided and we had to include our age structuring, because COVID affects different people from different ages very heterogeneously, right? So elderly people particularly had higher chances to get infected, develop severe symptoms, and so on. So it was inherent and important modeling COVID to include this heterogeneities in age patterns. So for each of these equations at each of these boxes, we had 20 extra boxes representing all the possible age groups. So if we have like, I don't know, 10, 15 equations here, multiply that by 20. That's the total number of equations in the complete model representing each of the age classes that we have in our demographic data. So that's only the baseline, and things start getting interesting when you modify this baseline. So how we modify this transmission rate, also called force of infection, based on interventions being applied to the population. So again, during COVID, we were mostly interested in non-pharmaceutical interventions, so social distancing, working from home, not closing restaurants, all this sort of things. All this sort of interventions, they affect the contact rates among different age groups. So we had to find out a way on how to measure this effect. And so we started using a bunch of data from, for example, the Google mobility reports or transport information data, such as number of passengers in main bus lines or subway in São Paulo city. All this sort of things we used to parameterize this effect. So it's a multiplicative effect that reduces the contact rates, particularly for more.
Wazazi watakuchunga kama mtoto mdogo, wewe sio mtu wa kindangani.
Sorry, does anyone ask a question or? Yeah, it's okay. If you have, if you have any questions in the middle, let me know. Otherwise, we also have some time at the end. But basically, yeah, we used this data to parameterize the effect of interventions in this contact rates. And which is not exactly very easy because it doesn't translate directly. The data doesn't necessarily is in the same unit or the same range that is coverage or effect in transmissibility. But more than that, we noticed for our model for Brazil that even using that proxy data and adapting the contact matrices was not enough to quite explain the data or to reproduce the dynamics retroactively that we saw for the disease. And we started thinking about that maybe there's something else missing because only taking it into account, school closures affect school contacts, work restrictions only affect work. Actually, all these interventions together are also affecting household contacts, not only within households, but between. Imagine that you stop visiting people during the pandemic also, and that also had to be included. And that's what we call here percolation approximation. And I'll talk a little bit more about that now. So this version of the model we produced only for the context of Brazil, and I think it was important there because culturally there was, but compared, for example, to the UK, there is a lot more of people living close by with their families and visiting each other on a daily basis, and that got really hit and affected by the social distancing interventions. And that's important because our mathematical models, the population level models that we are talking about, always have some underlying assumptions, particularly about well mixing. So everyone is as likely to mix and to contact each other and as anyone else, and homogeneity. So everyone is the same. Everyone has the same susceptibility to things, everyone has the same contact patterns, and so on. But of course, well, this is never completely true in any population, but it is even less true under those stringent non-pharmaceutical interventions during COVID, those stringent social distancing interventions. So basically what we are talking here is that the whole underlying network of connectivity between households was broken. So we couldn't completely rely on these homogeneity assumptions anymore. So we had to correct for that. And well, we noticed that, as I said, when we were trying to fit our model and we saw that it didn't really work very well. It only worked when we adapted the model to include these assumptions. So the idea here is that the homogeneity assumption is not good enough under the circumstances, because we have these interventions affecting the connectivity between the individuals. And we observed empirically that this connectivity was decreasing drastically with increased intervention. So we needed to find a way to explain that and to put that in a model. And we use network percolation theory for that, so where we connected this change in connectivity with crossing the percolation threshold as it's described in the theory. So we had to come up with a function with certain properties. I don't need to go over that, but basically the idea is that this function that will modify our connectivity, our contact rates, will have a much stronger effect after a certain level of NPI stringency or coverage. So basically, if you have like just a little bit of social distancing happening, like at the beginning of the pandemic or the very end, doesn't matter too much to take these things into account. But if you're right in the middle of, lockdown, schools closed and everything, there is a threshold after which these effects become quickly much heightened, and that they need to be taken into account. And that's the way we included that in our model. So basically we added an extra factor of 1 minus this function to modify the contacts in the households. And that basically we got a much better fit to data, much better explanation to data. So therefore we could trust our forecasts, our predictions a bit better. For those of you that are used to this terminology in mathematical model of modeling of infectious diseases, or even that heard of this kind of thing during the pandemic. Reproduction numbers was a thing that was talked about a lot as an index that helps you know like how fast the pandemic or the epidemic is spreading. So we calculated something that is called the basic reproduction number. That's the reproduction number when a completely susceptible population. And what that means is how many new infections are caused by each infection in a population. So if I am infected now and I am infectious for a week with COVID, how many people have I infected during that week? And that's what the reproduction number means. And what we calculated is that in the standard model, without having this percolation effects into consideration, wasn't a very good representation of what the basic reproduction number was supposed to be. It was even like bigger than one with all the interventions on, which doesn't make a lot of sense. If you think about it, if all interventions are locked down and etc. are on, an epidemic shouldn't take place, and reproduction number over one means that an epidemic can take place. And when we add our correction, so this the model with percolation, we have this effect, which makes much more sense. So basically, we are correcting the overestimation of cases when we have high coverage of interventions. So in summary, I hope that was not too technical. Depending on your background, it might sound a little bit too technical, but in summary, what we wanted to do is just bridge the gap between low-level individual-based or household-based models and this higher-level population models or compartmental models. So this very complex phenomena happening in the underlying network of connectivity that we weren't able to explore at the individual level because you don't have the data. We were able to come up with a mean field approach or a phenomenological approach, translating these emerging effects into our population level model. That means that not only we got better agreement to data in our model for our specific context, but also that meant the development of a new general approach where you have a better way to handle this heterogeneity in contact patterns applicable for any dynamic infectious disease, or really under this sort of conditions, when you have this sort of non-pharmaceutical interventions changing the patterns of connectivity in your group. So that was like one of the results, one of the things that we have produced during that period. But we also had a few other studies of interest that this particular model has been also applied as a baseline to a context where we were exploring, for example, quarantine and school reopening scenarios. So we had to take that percolation into account. But other models were also developed to answer different questions. So at some point we wanted to explore the transmissibility of an environment. So in that case, we had to develop a completely different model where you could be infected with one variant or the other, and the kind of results that we got from that were more like related to measuring the precision for the transmissibility parameter. The other example was the use of a different model for designing vaccination strategies. So that was more like an optimization sort of question. So we wanted to understand, based on the production rate of the vaccine and the different efficacies of different brands, what is the best strategy? Is it 1 dose, 2 doses? How fast? What is the interval between doses, and so on? So very different questions, and that led to very different models, even though the context is the same, the disease is the same. Another example of a project more recent, it was like a retroactive evaluation of the testing strategies. This was for the UK Health Security Agency. So we performed a retroactive evaluation of the testing strategies, and also produced this modeling tool where you could, at an individual level, you would track viral loads and timing of the tests that people were taking against viral loads, and how effective was isolation depending on the timing of the test. So that was a completely different modeling framework, but also because that was a different question. It was more about how effective is the test depending on when you test, in relation to when the infection started. So these are just a few examples, and I wanted to conclude covering a little bit about what are the lessons, and like how do we go forward from here? How do we prepare better for emerging epidemics? So I still think the mathematical modeling can be a very important tool to support evidence-based health policy making. But I think we need to focus on preparedness, and preparedness can be many things. It can be in terms of protocols, how to respond to emergencies on the ground, but it can also be about developing better methodologies that we can adapt faster to different diseases. So that testing model, for example, that we developed recently can be adapted for different viral load profiles and so on. And I also think the capacity building, so training like people like you guys, I imagine the PhD students in mathematical modeling and so on, training for that, being ready for that, and be involved in all of it in a participatory way. So even though sometimes, and some mathematicians or physicists, we might be tempted to just produce our models and work on our little equations in our own room, it's very important to talk to the people you involved, to key stakeholders from the beginning, to inform the research you're doing and produce results that are relevant. Another project I've been working on in terms of developing better methods is sort of the next step after this percolation model that I told you about. That approach was very phenomenological, so we were just trying to find a way to incorporate that behavior that we saw into the model, but without necessarily explaining it from first principles. So right now we are trying to explore how individual-based models or metrics in individual-based models and underlying network of connections can be translated into population-level models, not only for context, but also for other sources of heterogeneity, such as susceptibility, effectivity, and so on. In terms of capacity building, of course, teaching health data science and mathematical modeling here in Oxford, and also contribute to the malaria modeling and analytics doctoral training program. So Professor Sheetal Silal is a professor in the Department of Statistics in Cape Town, and she has launched this doctoral training program for future mathematical modelers, funded by Gates Foundation, and I think it is in its third year now. So there's a cohort of students from different parts of Africa training there, and I'm supervising a couple of the students there in projects, in this case applied only to malaria control and elimination, which is one of the another big interest of mine. And I'm not sure when and if she is going to be opening for new cohorts, but that's an excellent training program for anyone that wants to work in the field. Another project is with colleagues in Oxford, a PhD student, Ainura Maktova, that is finishing now her PhD. We've been working together to develop this model for HIV control, and also evaluate the impact of decentralization strategies. This is particularly for Kyrgyzstan, with focus on people who inject drugs. But this, in any case, this is a very relevant topic for LMIC and for vulnerable populations that are still susceptible to HIV. So another expect very interesting publications coming from Ainura in the coming months or year. And just to finish this whole thing, I wanted to mention a couple of quotes that I use with students sometimes, because I think I covered some more complex models as examples in this presentation, but models don't necessarily need to be very complex to be useful. They just need to be developed to answer the correct question. So if there is a correct and relevant question, you can make it, it is possible to answer it even with simple models. And we need to remember that whatever is the question, whatever is the model, it's always wrong in some sense, as it's never going to be a crystal ball predicting the future. It's always going to be just a tool with many limitations and many underlying assumptions. And as mathematical modelers, it's our job to communicate the limitations and assumptions if we are using that to inform health policy making. And whenever we are developing these things, it's always important to take into account context, and by context I mean environment, culture, political context, economic, and which is very difficult to do as a single person. So that's why we need to work as teams. We need to work with people that understand. I am okay doing the technical part of the job, but I know that I need to work with people in the field, treating people, implementing the interventions, and so on, to understand how they impact the population. And that's why also I think of mathematical modeling not just as a very scientific and thing, but also as a little bit of an art, because we need to take all these dimensions into account. We need to take experience into account. We need to add this human layer into the process. Otherwise, it won't be useful, and it won't make that much sense. I think in terms of content, that's it for now. If you need to contact me, I'm always happy to. Yeah, I just noticed that my email is wrong there. I'll just correct it in a little bit. It's ABDN in terms of Gmail, in place of Gmail. But yeah, I'm always happy to start new collaborations and to talk if you have ideas of new projects. But if nothing else, that's it from me, and I'm happy to answer any questions or hear comments or ideas that you have about it.
Thank you very much, Dr. Caroline Franco. That was a beautiful one. Thank you for your time. Nice presentation. Thank you very much.
Thank you very much.
So I want to know, are there some of us that have questions or comments? Questions or comments either from online or from those who are watching remotely, from anywhere you have questions? Yes.
Yeah, I can see some people in person there. It's actually very nice to see real people in this talk. So thank you for joining again. Yeah. So do you have a question in the room?
Yeah, there are questions. Thank you so much. Should we go ahead, sir?
Yeah, go ahead, please.
Okay, great. Thank you so much, Dr. Caroline, for that beautiful presentation. It's quite a complex model. However, I have a few questions right from the model diagram, the schematic diagram. If you can go there, I will appreciate.
Of course. The first one. This one?
Okay, it's okay. Yeah. Percent contact, is that right?
Sorry, I don't know if the mic broke. Can you repeat, please? I didn't listen to the
All
beginning.
right, no problem. So I'll say it again. I said at this point, I can see this equation written here, C at, yeah, which I have C ohm plus 1 minus work. So I guess this represents contact. Am I right?
Yes. So this C with a little hat actually means a matrix. So this is one of those each C here is one of these matrices like this that has all the information from contact rates between different age groups, and I represent them here as C hat. So each one of them is a matrix. So what we multiply by C hat is C work, for example, is this factor that is decreasing the contact rates in each element of that matrix.
Okay, thank you so much. So I'm interested in that part. I think that's where you factor the non-pharmaceutical intervention. So
exactly.
I want to know what all these factors are, and because I can, that's like you explained earlier that they have multiplicative effects. So I want to know what they are and how finally we arrive at the multiplicative effects. Then after that, I have a few more questions, and then I would.
Okay, no problem. So basically, like if we look at this C work matrix, for example, you have this whole thing multiplied 1 minus something. So it means that, you know, the bigger this something here is, the smaller the factor. So the smaller will be the effect of those contacts. So if work cov is the coverage of the interventions, work F is the efficacy of the interventions, and this theta is basically a time changing a time series, for example, saying like how it changes in time, in case the coverage is changing in time, I can modulate using this theta. But the whole point is that if you have high coverage, which means more people affected by intervention, and high efficacy, so the same in terms of work, for example, efficacy means if you are told to work from home, you work from home 80% of time, 30% of time. Do you comply with that or not? So that, and do you still meet people from work? So that might be included in this efficacy, for example. So yeah, so that's the efficacy of an intervention and coverage, and how many people, what the proportion of people in the population affected. So if you multiply all these things, and you will be decreasing this factor here, and therefore decreasing the contact rates.
Okay, so thank you so much for that. I was looking at the theta work to maybe I was thinking in my heart that maybe the theta work there might be looking like something like the residual of the intervention left per time. Am I right?
The theta, I think it was more like sort of a step function that could change in time, could be 0, 1. It depends on like if the intervention is on and off for how much time. So it was a way for us to control how long that intervention was on and off.
Okay, thank you so much. Then the next question, because I have 2 more. The next question here comes to the point where we have the exposed people coming to infected, hospitalized. So the hospitalized, I want to be sure of what happened here. The hospitalized compartment is what is broken into all these other types of hospital, other compartments. Have hospital treated, ICU treated, hospital required, so and then ICU required. So I want to know what's the difference between hospital required, hospital treated, and all this.
Yeah, of course. So the idea, our idea was that we wanted to use the model to represent how the system works. So we like, for example, in the databases, we have someone is hospitalized or not, or they have a severe symptom, but they had to wait that many days to have a hospital bed available, and so on. So being infected and having a severe infection doesn't automatically mean that you're gonna have treatment. So you need treatment, but you need to wait. So if so basically, like this first transition rate would be related to how long you wait to get the first level of treatment, and then there is a split between hospital. What we mean by hospital is actually just like normal hospital beds without without being an ICU or without having a ventilator. And the other type, the other branch here is people that needed treatment, including ICU and ventilators. So more specialized or more severe type of cases. Even within the severe. So that split was necessary because in our database for Brazil, we have these 2 types of bed, hospital beds. And then of course, you have people that are treated straight away, and there are people that still are waiting. So that's when these are the required. It's like you don't have enough beds, so we put some of them in this required compartment because they are still waiting. And that basically means, like, if someone needs a hospital bed and they do not get treated, they go into the required compartment and they continue not to get treated. That can lead to mortality. But of course, if they do get treated at some point, then they might recover. So I think I think we didn't want to make it too busy, but all this hospital compartments can get out of here. They all go through to recovered here. Okay, so they all can get recovered, but what we are trying to represent is that, there are different needs. People need different types of beds. And then sometimes they do get the beds that they need in the hospital, but sometimes they are just waiting for treatment and left untreated. So that's what it represents. And it can look different depending on the kind of health system that you have.
Okay, thank you so much. So the last question on this schematic diagram is for the recovered people. I want to know, is it an assumption here, or the biology of COVID-19 says so, that because here we are having immune people, does it, if a person recovers from COVID-19, does it confer immunity on somebody? It's a disease blocking kind of immunity on individual.
That's a very good point, and very well spotted, because this I think this diagram was from our models produced more at the beginning of the pandemic. We didn't even know if there was immunity or not. That's why there is a dashed line here, because we assume that there was a recovery. People can get recovered after a while and become susceptible again. So that's why there is this dashed line. But basically what we are assuming here is that once you are, past the infectious period, you are going to get recovered and be immune for a while. At the beginning of the pandemic, we didn't know how long. And also, first, because there was not enough time to have measured that. But also because there were different variants going on at some point. So that was another problem, because you might be susceptible to a new variant, but still have some protection against the previous one. So it's a good point that you asked that, to be honest, and that would depend on each disease. For the first models of COVID, for the first few months, or we would assume that there is some immunity, because we saw people recovering for that, but after that. But of course, after a while, after we learn more about the disease and about how more variants would impact this whole process, then you need to start considering what is happening in this dashed line. So people getting second infections, or becoming susceptible again, or getting infected by different variants. So, but usually there is an assumption of immunity after recovery, at least for a period.
Okay, thank you so much. Yeah, it's over for the schematic diagram, but I have two more questions. I don't know if it's permissible, not on the schematic diagram. One, it's on the percolation effects that you discussed. I'd like to know more about the percolation effects. And then, because I saw that in the reproduction number, it made a lot of difference that we're having the reproduction number coming down to 1 if we're having a percolation, but with standard model, it's not even able to reach 1. So I would like to know about that percolation. And then lastly, I would like you to talk about the fitting process. What kind of fitting method did you use to generate the fitting? Thank you.
for the basic reproduction number. So, like I said, we just need to be very, very careful here because this is a basic reproduction number. It's not the effective reproduction number. So, like I said, this is representing. Imagine the starting point of an epidemic in a fully susceptible population. And so this basic reproduction number is like, what if the population already had all these interventions in place, even without any infections? So that's important to an important note about calculating basic reproduction numbers. And basic reproduction numbers are properties not only of the disease, but also the population, the demographics, age structuring, all these things, and they can be obtained from the model structure. And basically, what we are showing here is that we have developed two models, with or without that percolation function, so that term multiplying the home contact matrices. And the difference between the two of them is that in the standard model, we always have higher reproduction rates, meaning that more people are infected after each new infection. And that's one of the interpretations of the basic reproduction rate is looking at its value. So if it is above 1, it means that each person infected will infect one more person. So that will establish an epidemic going forward. But if each person cannot infect at least one, that means that the epidemic won't get established. So there's going to be no epidemic. So that's why basic reproduction number are so important in the context of modeling, right? So what we are seeing here is that this is the basic reproduction number is always high at the beginning, like or if you have low intervention coverage or intervention stringency. And quite similar, but after the threshold where you have very high stringency, so a very high coverage, adherence, and efficacy of all the interventions applied, then they are very different. And the standard model will always be overestimating the amount of new infections that each infectious individual will lead to. And that's the point that you brought there, I think is the most interesting, is that it's overestimating it so much that is basically saying that there will always be an epidemic, even if you have everything locked down. So yeah, for this model, that's again, this is for this model, this population, that's the basic reproduction number that we calculated. But in general, the message is that there can be a huge overestimation if you don't consider such effects in populations that are so disconnected. And this disconnection, so the effect of social distancing causes these disconnections and decreases the contact rates in such a way that at some point the epidemic won't occur anymore because no one is contacting anyone, no one is infecting anyone. So that's the significance of this, is that underlying dynamics, the possibility of epidemic happening or not, or happening fast or not, it changes dramatically if we change this detail in the model structure. So I hope that makes sense.
It's that the percolation effect has to do with the disconnection between the population, that people not to contact themselves, and so it reduces the rate at which the disease spreads, and again having an impact on the reproduction number. So accounting for the overestimation that the standard model must have giving. So
Yeah.
I think I wanted to see the way, again, because I wanted to see the way you factor the percolation effects. So
Yeah.
it's one of the questions I asked, that how you factor the percolation effects in the model, that if you can show it again.
Yeah, so that's basically it. So we have this extra factor in front of the home context. And what we are saying is that this factor here, the FPERC, works like this. So there's a very dramatic increase around this threshold. So if you have lots of interventions going on, that will have a much stronger effect in the underlying contact network, and then your contacts between homes or within homes are going to decrease dramatically. That's where this effect comes from. And yeah, so that's what we try to translate with this formalism. And that's exactly what is translated also in terms of the basic reproduction number, is saying that, lots of interventions means that you should have less contact, you should have less transmission. So yeah, that's exactly it. And just going to your other question, I think I didn't even include slides. Let me check about the fitting, but it's we used a frequentist approach for fitting, and basically we used let me see if I can find.
Did you use the least square or the maximum likelihood?
Yeah, I have a few slides here about data fitting. Yeah, it's just a least square regression basically, and but for specific parameters. Let me just share this bit. Just that it's so long ago that I need to remember what were the names of the parameters that we use, just so I don't say anything imprecise. But it's
Okay. So are we done with that aspect?
yeah, can you see my screen still? Yeah.
No, not again. Not anymore.
Okay. Yeah, so yeah, it came out of the slide sharing, so I think I messed it up. Just a second, sorry. Can you see the screen?
Yeah, we can see it now.
Yeah, sorry, I found it. So yeah, just to give some details about fitting. So parameters that we fit are first the percolation threshold, because there's no way to measure that in any way. So that's a phenomenological parameter. So we have to fit that to data. We fit the probability of infection per contact, which is also another thing that cannot really be measured, and that will in fact impact our force of infection. And the other thing is the start date, because the start date of the epidemic is always very difficult to know, even though we have the date of the first registered case at the start of the any epidemic. You have, you know, lots of noisy data, because you might not simply have not detected exactly the first case. So we fit that to the best start date. So basically it's just shifting the time series a little bit to fit the model. And we fit that to data from severe respiratory syndrome in São Paulo. And that's not COVID data, because COVID data was not reliable due to the lack of testing. So I think in many places you didn't have enough tests to be able to say that number of COVID cases is the actual number. We measured it by severe acute respiratory syndrome, because that's what was very clearly changing in hospitalizations and so on. And we only fit it to severe because also, like I said, no mild cases were ever reported, or if they were reported, were different systems, and like test positivity and reporting rates were all over the place. So you cannot trust that. So we had to go with the severe notifications, and we fitted both for cases and deaths, new cases and new deaths, so incidents basically. So to get the best possible result. And yeah, if you look at the publication, there will be much more detail, but I think I already took too long to answer this one, but that's basically the summary of the method.
All right, thank you so much. So we're going to move to the next question now. Okay, Prof. Sir, another person is raising up his hand. Anas Musa.
Is it within the center or outside?
No, outside. It's virtual, sir.
Okay, so let the person, you can allow the person to unmute.
Okay, so Mr. Anas, you can go ahead, sir.
Okay, please, can you go to your diagram?
Yes, of course. Now I learned how to navigate it, so.
Yeah, I have just two questions. Can you go to the other one that has the equations as part of the diagram? Not this, sorry. I don't know whether
This one.
Yeah, this one. So my first question is concerning the first term that you explained, 1 minus work of and then work EFF and then theta of T. I heard you mentioning that the bigger the second term after the minus sign could be big enough to determine whether we'll be having a negative here or positive. Is that the case? I want to know. So what are the values of these variables here? What are the ranges of these variables here? Are they yeah,
Coverage.
Yeah.
So coverage, efficacy, they are indexes, right? So you can think about them as, of course, percentages. So 30%, 100%, whatever, but they are always converted to an index between 0 and 1. And same for the theta, it is just a modulation of a time series of coverages. So all of these things are less factors of numbers less than 1 multiplied. So the whole factor will always be less than 1. So the whole so I'm talking about the factor after the minus sign. So 1 minus it will also be between 0 and 1.
Yeah, but I have a concern here. The whole factor after the minus are multiplying each other, right? And if they are all in percentages, I think it won't be the case where they will all
They are not percentages. They are just an index between 0 and 1.
always be between 0 and 1. For instance,
Yeah, so if it like
the work efficiency
30%
is also
would be
0.9.
would be 0.3, 50% 0.5, so and so on. So always, yeah, it will always between everything between 0 and 1.
Okay. And then my last question is I've seen that in in your diagram you were able to capture the this can I show this this parameter.
Yeah.
Yeah. So
Sorry, I think I missed the
but
question. Can you repeat?
What I said is that I have seen that you've been able to capture this parameter from the data that. Hello?
Yeah, I can, it's breaking a little bit, but I think I can hear. You wanted to know about how I use the data to calculate the force of infection, the lambda?
No, that is not the question I want to ask.
Okay.
I was saying that is it that your interest is only in this parameter? Because I was expecting that there should be parameters here that should be indicated.
Oh, yes.
Yeah.
Yes,
So is
of
it that
course.
your
Yeah.
interest is only on this? Yeah, that's what I mean. Yeah.
Yeah, thank you. This is a very summarized diagram, like I mentioned, like not even necessary all the arrows are here because otherwise it would be a little bit too convoluted. Let me see if the other diagram that I have. Yeah, so yeah, even this diagram that I have for the same model also doesn't have the parameters, but basically we would have all the parameters in the equations that I show. So there is a lot of parameters here. And these parameters are informed by literature, they are informed by data. So particularly like for the hospital admissions, we had to get hospital admission data and aggregate it by the different types of hospitalizations and get hospitalization rates depending on the type of the disease, symptomatic presentation, for also like for disease severity. We also use data to inform all these rates, recovery. So everything is related to some to parameters in these equations. So it's all informed by either data from literature or data from that we collected from healthcare system. And of course, some things might be fitted to data, but yeah, I didn't include all the parameters in that diagram.
Okay, thank you very much.
You're welcome.
Okay, thank you so much.
Any other question?
Okay, there's a question in the chat. So the person, Mr. I don't know if it's Mr. or Miss Marcia, it said, thank you so much for the nice presentation. Please, dear Caroline, have you think about partial differential equations model in the field? What about stochastic cases?
Yeah, so I mean, in other applications, yes, we might use partial differential equations, stochastic models. I think some of our malaria models that I did some work with would have some stochasticity because you need to take in account the the stochastic probabilistic effects of certain things, certain especially related to transmission. In this case, no. This case is completely deterministic. We only use deterministic, so ordinary differential equations, because it was already complicated enough, and one of the things is that like we don't want we just want to make it as complicated as it needs to be. We didn't have more data or more parameters to be able to inform a stochastic model at the time, and even spatial models. Some of our collaborators, I know that people in Marcia in Cape Town have developed some spatial models, but it wasn't even partial differential equations. It was just patch models. So you would have like some kind of connection, migration type of thing, connecting a spatial patches. So different regions are represented by different models simply connected by migration, for example. So all that sort of things are possible, and different models might have integrated it. The ones that I worked with were deterministic, ordinary differential equations, and we only focused in one city at a time. So even the one that I mentioned afterwards about like schools and reopening and different cities, different strategies in different cities. Even these ones, we fitted the model for each of the cities because it was already complicated enough to develop and parameterize the model for each different place. So we didn't attempt anything more complicated, but yeah, I mean, it can be quite relevant in some contexts to include that level. I hope I answered the question. I'm not sure.
Yeah, so I just want to add this, like for PD, for epidemiological questions, like epidemic models and all that, PD is not always a very useful tool. For PDs, you can look at things like fluid flow, climate, and all that to be good in that area. But when it comes to epidemiological models, I mean, most times it's always tending towards meta-population models. Like so then for stochastic model, when the population is getting too high, the law of large numbers may actually, make the stochastic model to be not relevant, because it's always good to use the stochastic when the disease has just emerged, like at the beginning of the epidemic, when we are seeing a lot of uncertainty, randomness, and all of that. That would be the best time to use the stochastic model going forward. Over.
Yeah, thank you. And that's exactly the point, is that sometimes it's too complicated already, so we wouldn't even have, and it wouldn't be necessary to add at this extra level. Yeah.
Thank you. So then I also want to say that I want to ask, because you were using the data you use has to do with incidence data. And I would like to know, what are those parameters that you estimated from your model? Because I know that for incidence data, you cannot use incidence data to estimate certain parameters that are clinically oriented. So I would like to know, what kind of parameter did you estimate, given the model, also given the kind of data you are using? Over.
Yeah, so we used new case and new deaths, which is sort of like incidence. And the parameters that we estimated, like I mentioned, like part of the model fitting, were start of the epidemic, probability of infection given given a contact, those sort of parameters that cannot be inferred from anywhere else. But we try to use data from literature for everything else. And yeah, I'm not sure that was the question. Yeah, but for the other parameters, like I said, we use data for those parameters also. But that was not exactly fitting. It was just processing the data and using that to calibrate the model.
And I guess they should be in the range, not fixed, right?
Yes, yeah. So yeah, we also had to process it and convert it to the range that we were using. So we had hospitalizations per week, and we had to convert that into hospitalization rates per time step in the model and so on. So yes, that is a lot of extra levels of data that I couldn't even include here. And lots of other people also, like I didn't do the whole thing. We had a whole group aggregating the data and preparing the hospital rate data to feed it into the model. So yeah.
Thank you. So are there other questions before we release Caroline to leave?
No questions there, sir.
Okay, no questions. It's been very engaging, and I think we have taken much of our time today. You know, thank you very much for coming. It's been a nice time having you around, and I also believe that if we call you at another time, you'll be available for us.
And thank you so much again for inviting. It was very good to share a little bit, and it's always good to see new faces. So I'm happy that I can see some faces, and and connect again. Hopefully we will have more opportunities to collaborate in the future.
Yeah, thank you very much for your time.
Thank you.
So can we do an online clap? If you have online clap, you can clap for her. And then wherever you are, you can give her a round of applause. Thank you very much.
Thank you.
All right, bye. Take care of yourself.
Bye-bye.
Cheers. Yeah, bye. Cheers.
Say okay. Where's Prof? Prof is not here. It's Mr. David. Bye-bye. Okay. Say cheese. Yeah, I'm just playing. So it's your participant.
Ciao, ciao. Goodbye, everyone. Bye-bye.